Welcome. In this session we will be discussing orbital trauma, and this topic lies in the confluence of the specialties of maxillofacial surgery, oculoplastic surgery and neurosurgery. Midfacial fractures, also called Lafoot fractures, are fractures of the maxilla which by definition extends posteriorly to involve the pterygoid plates of the sphenoid bone, and they are typically classified into three types, although a fracture in an individual patient may not belong to any one of the three types and instead be a combination of the types. So in a level 1 fracture, there is a transverse fracture line above the teeth but below the orbit. So a level 1 midfacial fracture does not involve the orbits. In level 2 midfacial fracture, there is a pyramidal fracture line involving the medial portion of the orbital floor, the medial orbital wall and the nasal bones. And in level 3 midfacial fracture, lateral wall of the orbit, the orbital floor and the medial wall of the orbit are all involved. And usually in a level 3 fracture, there is a craniofacial disjunction in which the facial bones are connected to the base of the skull by only soft tissues instead of bone. So orbits are involved in level 2 and level 3 midfacial fracture, and treatment of midfacial fractures involve dental stabilization and open reduction of the fracture with internal fixation. In zygomatic fractures, also called fractures of the zygomatic or maxillary complex or ZMC, the fracture line involves all the four junctions of the zygomatic bone, and so they are called quadrupod or tetrapod fractures. And these are the zygomatic arch with the temporal bone, the frontozygomatic suture with the frontal bone, the lateral orbital rim with the maxillary bone, and again the maxillary bone at the lateral wall of the maxillary sinus. If there is no significant displacement of the zygomatic bone, surgical repair is not required. But if there is significant displacement, there can be displacement of globe and lateral canthus. Displacement of the globe can lead to diplopia, and here we see inferolateral displacement of the lateral canthus. Trismus can occur due to spasm of the adjacent muscles, leading to an inability to open the mouth during chewing and talking. Significant displacement needs surgical repair, in which accurate realignment of the lateral orbital wall and lateral wall of the maxillary sinus are indicated, and this can be done through an eyelid and or buccal incision. Incisional approach to the orbit will be discussed in the next session when we deal with orbital surgery. Orbital apex fractures are usually associated with fractures in adjacent bones, including the skull, face and the rest of the orbit. Orbital apex fractures can involve the optic canal and the superior orbital fissure and injure the structures passing through them, leading to traumatic optic neuropathy, carotid cavernous fistula and CSF leakage. Traumatic optic neuropathy we have discussed in the neuro-ophthalmology section, and carotid cavernous fistula we have discussed in the session on vascular lesions of the orbit. Orbital roof fractures are more common in children, and they can occur with blunt trauma and with missile injuries. Orbital roof fractures are more common in children because in children there is delayed pneumatization of the frontal sinus, and the frontal sinus acts as a shock absorber and prevents spread of the fracture line during the trauma. Also in children, the cranial wall to midface ratio is larger than in adults, and as a result during the fall there is greater likelihood of impact on the frontal bone. So here we see a patient with injury of the orbital roof in the left side, which results in a subperiosteal hematoma inside the orbit, leading to proptosis. So an orbital roof injury can result in intracranial injuries and pneumocephalus, leakage of cerebrospinal fluid, pulsatile proptosis because of transmission of intracranial pulsation into the orbit, ptosis and extraocular muscle dysfunction due to edema and contusion of muscles and nerves adjacent to the orbital roof, but entrapment of muscle and soft tissues, as we will be discussing later in this section, is rare with orbital roof fractures. Subperiosteal hematomas can occur, as we see here. Ecchymosis in the upper lid can be found, which can actually be delayed after the trauma occurs. The fracture of the orbital roof per se often heals on its own and does not require any treatment. Fractures of the medial wall of the orbit can be either direct when it is called a naso-orbito-ethmoidal or NOE fractures, or indirect when it is called a blowout fracture. NOE fractures occurs from direct trauma when face strikes a hard surface, and it involves the frontal process of maxillary bone, lacrimal bone and ethmoidal bone, which all lie along the medial orbital wall. It can also involve the nasal bone, which makes up the bridge of the nose as we see here. NOE fractures can be classified into three types. In type 1, the bone attached to the medial canthal tendon is fractured. In type 2, the bone attached to the medial canthal tendon is comminuted. And in type 3, the medial canthal tendon itself is avulsed from the medial orbital wall. Clinical features of NOE fractures are depressed bridge of nose, traumatic telecanthus, that is lateral displacement of the medial canthus because of weakening of the medial canthal tendon, severe epistaxis from injury to the anterior ethmoidal vessels which pass from the orbit into the nose through the frontoethmoidal suture, CSF rhinodia if the cribriform plate is involved, injury to nasolacrimal drainage apparatus which lies along the anterior portion of the medial orbital wall, subperiosteal or orbital hematoma, orbital or subcutaneous emphysema, emphysema meaning accumulation of air within the soft tissues, and it results from violation of the wall separating the orbit from the sinus. So when there is a medial orbital wall fracture, patients are advised not to blow the nose to prevent orbital emphysema from occurring. Orbital emphysema is a cause of orbital compartment syndrome, which we will be discussing later in this session. Treatment of direct fractures of the medial wall of the orbit requires open fracture reduction and plate fixation. Indirect or blowout fractures of the medial orbital wall usually occurs as an extension of blowout fractures of the floor, but isolated blowout fractures of the medial orbital wall can also occur. By definition, in an orbital blowout fracture, the rim of the orbit is intact and is not fractured. Clinical features of blowout fractures of the medial orbital wall include diplopia and enophthalmos from muscle and soft tissue entrapment, and diplopia and enophthalmos is also found in blowout fractures of the orbital floor, as we will see. And when there is diplopia and enophthalmos, medial orbital wall blowout fractures require surgical repair. In this CT scan, we see prolapse of the orbital contents through the fractured medial orbital wall into the ethmoid sinus. Other signs which may be found in blowout fractures of the medial orbital wall include orbital emphysema, subperiosteal or orbital hematoma, and epistaxis, which are also found with direct or NOE medial orbital wall fractures. When the medial orbital wall blowout fracture is associated with blowout of the orbital floor, surgical repair is done through an inferior eyelid or a transconjunctival incision, giving access to both the orbital floor and the medial orbital wall. But in case of an isolated medial orbital wall blowout, the surgical approach is usually retrocaruncular or frontoethmoidal. Orbital floor fractures like medial orbital wall fractures can also be either direct or indirect, indirect being called blowout fractures. Direct orbital floor fractures are caused by an impact to the inferior orbital rim and are associated with fracture of the inferior orbital rim. Indirect or blowout fractures of the orbital floor are not associated with fracture of the inferior orbital rim as per definition of orbital blowout fracture. And there are two theories to describe the mechanism of occurrence of a blowout fracture, whether of the orbital floor or the medial wall. One is the hydraulic theory and the other is the buckling theory. The hydraulic theory states that the impact on the orbital aperture with an object larger than the diameter of the orbital aperture momentarily occludes the orbital aperture with momentary increase in the intraorbital pressure. And this momentary increase in intraorbital pressure is severe enough to make the orbital wall give away or blow out at its weakest portion. And the weakest portion of the floor is its posteromedial portion made up of maxilla. The buckling theory states that the pressure of an impact deforming the inferior orbital rim is transmitted to the orbital floor without fracturing the inferior orbital rim. And this transmitted force then fractures the orbital floor at its weakest part, that is its posteromedial portion. So this is a CT scan of a patient with a large blowout fracture of the orbital floor. And patients with orbital floor blowout fractures have an history of orbital impact with an object larger than the orbital diameter. Ecchymosis and edema of the eyelids are usually present, but they can be absent also, and then it is called a white-eyed blowout fracture. The main clinical signs of orbital floor blowout are limitation of ocular movements, enophthalmos, and hypostasia in the distribution of the infraorbital nerve. So in orbital floor blowout, we find limitation of ocular movements, particularly in the vertical direction, either in supraduction and or infraduction. The limitation in supraduction is usually due to restriction of the inferior rectus, and the limitation in infraduction is due to weakness of the inferior rectus. And occasionally movement limitation in horizontal direction is also found when the nerves to the horizontal muscles are also involved. And attempted vertical ocular movements results in inferior orbital pain. The most common cause of limitation of ocular movements is edema and hemorrhage in the orbit, and not due to entrapment of muscle and or soft tissues in the fracture, and this is very important to remember. When the ocular movement restriction is due to edema and hemorrhage in the orbit, FDT shows no restriction, and the movement limitation disappears in several weeks when the edema and or hemorrhage subsides. Less commonly, limitation of ocular movements in orbital floor blowout fracture is due to entrapment of the inferior rectus muscle through the fracture. This photograph shows soft tissue entrapment following orbital floor blowout, and this photograph shows entrapment of the inferior rectus muscle following orbital floor blowout. And entrapment of the muscle is more common in children, which is very important to remember when we encounter pediatric orbital trauma and they require emergency treatment. Entrapment of the inferior rectus muscle results in limitation of supraduction, rise in intraocular pressure in attempted upgaze as compared to primary gaze. Forced duction testing shows restriction of the inferior rectus muscle, and forced duction testing can also confirm release of the entrapped tissue intraoperatively. During eye movements or during forced duction testing, there can be pain, nausea, and bradycardia due to stimulation of the oculocardiac reflex. Oculocardiac reflex can be due to the entrapment of the inferior rectus muscle itself. And unlike movement limitation due to edema and hemorrhage in the orbit, movement limitation due to entrapment of muscle or soft tissue does not subside spontaneously. The third cause of movement limitation is damage to the extraocular muscles or their nerve supply, and this may involve the horizontal movements also, as we have mentioned. In addition to limitation of vertical ocular eye movements, other signs of orbital floor blowouts include enophthalmos and globtosis. Globtosis meaning inferior displacement of the globe. And these occur when there is a large fracture allowing orbital soft tissue to prolapse into the maxillary sinus. And if in addition to an orbital floor blowout there is medial wall blowout also, additional tissue will also prolapse into the ethmoid sinus, increasing the severity of the enophthalmos and globtosis. In the initial few days after the orbital trauma, enophthalmos may be masked by hemorrhage and edema and may become apparent only after several days to a few weeks. There will be hypostasia in the territory supplied by the infraorbital nerve, which includes the area from the lower eyelid inferiorly. Subcutaneous and orbital emphysema can also occur with fractures of the orbital floor, but they are less common than in medial wall fractures. So three important signs of orbital floor fractures are very important to remember. One is the limitation in vertical ocular movements, second is enophthalmos, and third is hypostasia in the distribution of the infraorbital nerve. Most orbital floor fractures do not require surgery. Oral steroid administration reduces the edema and thus also helps in early decision making if surgery is required or not. However, one definitive indication for surgical repair of orbital floor fracture is pediatric orbital floor fracture, when CT scan shows inferior rectus muscle entrapment within the fracture, and in this situation fracture repair needs to be urgent. And in children, there is a higher risk of the inferior rectus being tightly trapped in the fracture, and this is called a trapdoor fracture. Trapdoor fractures typically occur in children because of the elastic nature of their bones. Following a linear fracture in the floor of the orbit, a flap of bone moves downwards towards the maxillary sinus along with the inferior rectus muscle and/or its attached tissues, followed by the return of the flap of bone to its original position, trapping the prolapsed tissue. And urgent repair prevents ischemic injury and development of fibrosis in the trapped muscle. There are other situations in which the recommendations to operate or not are more controversial, and the decision in these situations are taken only after 2 weeks following the orbital trauma, when the edema and the hemorrhage has subsided. And these situations include diplopia occurring within 30 degrees of vertical excursion from the primary position with positive FDT and CT scan showing a floor fracture. Enophthalmos more than 2 mm when compared to the other eye, and a large fracture involving more than half of the orbital floor, particularly if there is an associated large medial wall fracture. So for surgical repair of orbital floor fractures, usually a transconjunctival approach is taken along the lower fornix, along with lateral canthotomy and inferior cantholysis for better exposure, followed by entry into the subperiosteal space by lifting the periosteum over the orbital floor and then releasing the entrapped tissues, followed usually by placement of an implant. So here in this picture we find a polyethylene implant being placed over the fracture in the orbital floor with a screw. Surgical repair of orbital floor fractures has its own set of complications, including undercorrection or overcorrection of diplopia and or enophthalmos, loss of vision due to injury to the optic nerve, injury to the infraorbital nerve, retraction of the lower lid, injury to nasolacrimal drainage apparatus, and extrusion of the implant, which can occur early or late following the surgery. Orbital foreign bodies and orbital compartment syndrome can occur with fracture of any of the walls of the orbit as well as without a fracture of the walls of the orbit. CT scan is the preferred imaging method to localize a suspected orbital foreign body, and an MRI scan should be avoided in case of suspected metallic foreign body. However, a CT scan may fail to pick up an organic foreign body, which may be better imaged by MRI. Management of an orbital foreign body includes culturing the wound and or the foreign body and administering antibiotics, followed by removal of the foreign body. Foreign bodies in anterior orbit, as seen here, can be easily removed, and organic foreign bodies need removal because they are prone to cause orbital infection. And if a draining sinus has already formed, the foreign body can be located and removed through that sinus. Posterior inert foreign bodies without sharp margins, such as gun pellets, does not require removal. So a metallic foreign body in the posterior orbit without sharp margins does not require removal, whereas a metallic foreign body inside the eye should be removed because it is prone to cause toxicity inside the eye. Orbital compartment syndrome occurs due to an acute rise in the intraorbital pressure due to either hemorrhage or air. Air we have discussed when we mentioned orbital emphysema following orbital wall fracture adjacent to the sinuses. An orbital compartment syndrome can occur following trauma and also following orbital surgery, retrobulbar or peribulbar anesthetic injection, and also following orbital diseases. Clinical features of orbital compartment syndrome include loss of vision, and loss of vision occurs due to compression of blood vessels as well as actions of the optic nerve, and also due to central retinal arterial occlusion. The loss of vision can be rapid, profound and permanent, so we need to intervene immediately when we encounter a patient with orbital compartment syndrome. RAPD will also be there due to injury to the optic nerve. We'll also find raised intraocular pressure. We'll also find the tight orbit with proptosis and restriction of ocular movements. A tight orbit is a very important sign of orbital compartment syndrome. As we have mentioned, emergency decompression of orbit should be done immediately when we encounter a patient with orbital compartment syndrome without waiting for imaging. So if a patient develops an orbital compartment syndrome Following a retrobulbar or peribulbar anesthetic injection, we have to intervene immediately to protect the patient's vision, and this is very important to remember. If orbital compartment syndrome occurs following orbital surgery, the incision of the orbital surgery should be opened, the blood drained, and active cautery of the bleeding vessel should be done. Otherwise, such as in a situation of an orbital compartment syndrome following retrobulbar anesthetic injection, a canthotomy and a cantholysis should be performed immediately. Canthotomy and cantholysis disinserts both the eyelids from the lateral orbital rim, thus allowing the orbit to expand anteriorly. And both superior and inferior cantholysis should be done. Only lateral canthotomy without cantholysis does not work for a patient with orbital compartment syndrome. Following surgical decompression of the orbit, parameters such as vision, pupillary reaction, and intraocular pressure should be continuously monitored to decide whether further decompression is required. Traumatic optic neuropathy can also occur with orbital trauma, and we have discussed traumatic optic neuropathy in the section on neuro-ophthalmology. Thank you for listening.